Good morning, everyone. Today I'll be talking about serial extraction. Serial extraction is basically a part of an interceptive orthodontic procedure. It's one of the interceptive orthodontic procedure where there's some malocclusion that's already happened, and you're going to intervene in order to prevent it from worsening. You predict something is going to happen. It's going to end up in a malocclusion, and you do a procedure in order to avoid the severity of the consequences. Okay. So let's go into serial extraction. Let's see the definition of serial extraction. Serial extraction is basically an interceptive orthodontic procedure initiated in the early mixed dentition when one can recognize and anticipate potential irregularities in the dentofacial complex and is corrected by a procedure that includes planned extraction of certain deciduous teeth and later specific permanent teeth in an orderly sequence and predetermined pattern to guide the erupting permanent teeth into a more favorable position. It was first coined by Kejelman in the year 1980. So it's basically an orderly sequence, like we anticipate the malocclusion and we plan and extract certain teeth in order to achieve a proper occlusion, so that by the time the tooth erupt, it will erupt in proper alignment. Okay. So what is the rationale? Basically, why do we choose serial extraction over normal fixed orthodontic? Why is it better? Because basically we identify some arc-length tooth material discrepancy, and this is more physiological tooth movement. We do not put appliance in the patient's mouth. We do not pull the teeth according to the position that we want. We just plan some extraction, we remove the teeth, and the tooth erupt in its own physiologic manner into normal alignment. What are the indications? So serial extractions, basically, you cannot give it in severe malocclusions. You can give it in the case of class 1. If it's class 2 or class 3, serial extractions are contraindicated. There is minor arc length tooth material deficiency. When you can anticipate, if an 8-year-old child comes to your clinic, and you can see that even after growth, this will not overcome the discrepancy. It's not going to, there's a discrepancy that's there. And over a period of time, if the growth can correct the malocclusion, so we have to anticipate that. If you can realize that it's not going to change any, there's not going to be any improvement with growth, then you can stick on to serial extraction. And there should be a straight profile and creasing appearance. So basically, we are dealing with tooth. Only when there is a tooth and arc length discrepancy, we are going to do this. Okay. Severe malocclusions that have convex profiles and where there is extraction that's warranted after complete eruption of permanent teeth, we cannot do serial extraction. So next comes contraindications, where all the similar. I have already mentioned about all these class 2 or class 3 malocclusion, skeletal abnormalities, when there's too much of space dentition, when there's anodontia or oligodontia, when there are already missing tooth, but you extract a tooth by mistake, then you're going to end up with more space. So you cannot do that. When there is vertical discrepancies like open bite, deep bite, the overbite has to be ideal. When there is midline diastema, or when there's class 1 malocclusion with minimal space deficiency, you can anticipate. Okay, after permanent teeth eruption, this is going to get corrected. Then we should not go for serial extraction. Or if there is any unerupted malformed teeth or extensive caries, mild arc length tooth material discrepancy, in these cases, we do not go for serial extraction. What are the advantages? Just like I told before, the tooth movement is more physiologic. So treatment is more physiologic. So there's avoidance of any psychological trauma. So the child, like at an early stage, psychologically, the child may feel his or her teeth is not nice. So you can avoid all that psychological trauma. The tooth erupts in normal alignment. It basically reduces the duration of multi-banded fixed treatment. There's better oral hygiene. The health of the investing tissues are preserved. Because it's more physiologic, there is lesser retention period that's indicated because the tooth are going to erupt. They are going to erupt in the physiologic manner. We are not inducing any active force, which we have to give any, which we have to retain by any appliance. So lesser retention period is needed. Therefore, there is more stable results. Disadvantages. Basically, if the orthodontist fails in its clinical judgment and if he goes for serial extraction, then it is a problem. So it requires clinical judgment. Since we have to observe the child for a long period, this prolonged treatment time, the patient has to visit frequently because we have to observe the patient. And since we extract even before the eruption is happening, there's a frequency of eruption, like the lateral tongue thrust may develop. Like if it's going to take some 3 months to 4 months for the permanent teeth to erupt, this extraction space tongue thrust may develop. Now, extraction of buccal teeth, a lot of buccal teeth can lead to deepening of bite. The risk of arc length deficiency, if reduction, if the extraction is not planned properly, if it's not planned at the proper time, then we may anticipate, like sometimes the permanent teeth may drift. We erupted before, we extracted before, and the permanent teeth is taking time. So in that period, the arc length may be occupied by the adjacent teeth. So that time the risk of arc length reduction may be there, or ditching of space between canine and secondary molars can happen. And basically, the axial inclination should be corrected. Even though we sometimes serial extraction we do, they may warrant some need of fixed appliance at a later stage. So what are the three methods? Basically three methods. One is duals, one is Nance, and another one is tweed. So duals method is where we extract the deciduous canine. First is the extraction of deciduous canine at the age of 8 to 9 years. Permanent canines are up around 9 to 10. So we plan and extract the deciduous canine at around 8 to 9 years. Okay. So this is the first teeth. So we are extracting C followed by D, which is a year later, say about 9 to 10, because 11 to 12 is the time when the first premolars erupt. So deciduous first molars are extracted around 9 to 10, followed by extraction of the erupting. When the erupting first permanent premolar is erupting, we extract it. So duals method is C, D, followed by 4. So basically deciduous canine C at the age of 8 to 9, a year later, 9 to 10, we extract the deciduous first molar, and later we extract the first permanent premolar when they erupt. Other methods are tweed and Nance. So tweed's method is basically they go for extraction of deciduous first molars around the 8 years of age. Okay. So 8 years of age followed by extraction of the first permanent premolar. So when they erupt and the deciduous canine simultaneously. So here the order is reversed where they extract D at the age of 8 to 9. And they simultaneously extract the erupting first permanent premolar and the deciduous canine, simultaneous extraction of both. Nance method is similar to Tweed's technique where they extract the deciduous first molar first, followed by extraction of first permanent premolar and the deciduous canine. So both these are D4C. Where you can use a code word for duals method CD4. So this is about the serial extraction. So serial extraction is one of the very important procedures that we need to learn in interceptive orthodontics. Thank you.